Hi everyone. Today we are going to talk about temporomandibular disorders in oral surgery. So I have taken all the slides from MSD. In case you are trying to refer a book, you can open the page in MSD and you'll find the content very similar. So now coming to temporomandibular joint disorders. So there are different kinds of disorders. One is myofascial pain, disc displacement disorders, and degenerative joint diseases. We are going to talk about all of these things in detail. Systemic arthritic conditions and chronic recurrent dislocation, ankylosis, neoplasia, and infections. So first one is myofascial pain disorder. Myofascial pain disorder is the most common cause of masticatory pain and compromised function. The symptoms are diffused pain. Here you can see there are referred pain from the trigger points. These are the different primary pain regions. The symptoms are diffuse, poorly localized pain in the preauricular region here, often involving other muscles of mastication. The pain and the tenderness develop as a result of abnormal muscle function and hyperactivity. A parafunctional habit, clenching, posturing, and bruxing, may be etiologically related to this clinical entity. It can also be the result of disc displacement disorders and degenerative arthritis. Where facets may be seen in the patients. In those patients with the nocturnal parafunctional habit, symptoms are often worse in the morning. So these are the points that I made from this. So this is a common cause of masticatory pain. Symptoms are diffuse pain is there, pain in the periauricular region can be seen involving muscles of mastication. It can be related to bruxism, clenching, and at nighttime, some patients have this habit of clenching. You can see the wear facets in them, and the symptoms are worst in the morning. So the pain is severe in the morning in those patients. Now, disc displacement disorders. So before I talk about disc displacement disorders, here you can see the temporomandibular joint. Okay, this is the mandible. This is the mandible. And this is the articular disc in between. And it joins the lateral pterygoid muscle. And behind the articular disc is the retrodiscal tissue. So I hope you already know about the anatomy of TMJ by now. If not, just look at the picture of the TMJ to understand better. So again, this is the joint. This portion is called as articular disc. Okay, and it joins into the lateral pterygoid muscle, and behind that is retrodiscal tissue. So there are two movements we already know for the mandible. So during that movement, what happens is the articular disc is in a fixed position. Sometimes when the mandible, when we do different kinds of extreme activities like opening mouth really wide, or during any ortho treatment, sometimes what happens is the retrodiscal tissue will come in the place of the articular disc. And so let me just explain again. This is the mandible, okay? And now this is the joint. Now this is the articular disc, okay? So even though this is present here in this position between the bones, what happens is this is avascular. So there is no pain. We are able to, you can see when you try to move your mandible side to side, open it and close it right now while listening to me, you'll be able to do it very easily. But when you open the mouth too wide, what happens is this can move front, and this is something it will look like. So the articular disc has moved front, and then you can see the retrodiscal tissue, which is very vascular, taking over the place, and then it causes extreme pain. And if it remains in that pain for in that same place for a long period of time, what happens is there are chances that retrodiscal tissue will be permanently there and it will be a little less painful. But this is what happens when there is disc displacement disorders. Disc displacement disorders are seen with and without reduction. So I'll be talking about with and without reduction. First, let's have a look at the notes over here. For the wider movements of the mouth, the condyle and the disc have to move out of the socket. Like I said, the condyle has to move out of the socket, forward and down the articular eminence. A convex bone surface located anteriorly to the socket. This is translational movement. When you're moving, when the wider movements of the mouth is there, the condyle and the disc has to move out of the socket. When the mouth opens, mandible moves, rotational movements of the condyle occurs within socket. Okay, so let me just move this over here. Yeah, now, in the disc displacement, the disc is dislocated anteriorly and the retrodiscal tissue is pulled between the two bones. And it's a painful condition. Click sound with reduction. Like I told you, in this condition where the retrodiscal tissue goes in the place and it is pulled in between the two bones, you hear a click sound with reduction. Okay. Now, when do you see a lock? When there is no reduction. Condyle is stuck, resulting in limited range of motion and ipsilateral deviation on opening. If one side is affected, mandible is deviated. So it is deviated on one side, okay, and one side is normal. So you can see mandible deviated towards the lock side. So these are the two disc displacement disorders. They are seen with and without reduction. With reduction, you see click. Without reduction, you see lock. Okay, the return of the normal disc to condyle relationship. When reduction is present, normal interincisal opening without deviation can be seen in spite of joint and muscle tenderness. When reduction is present, so whenever there is reduction present, you can still see interincisal opening in spite of the pain and joint and muscle tenderness. The opening click corresponds to the condyle moving over the posterior area of the anteriorly displaced disc, resulting in reduction. The reciprocal click occurs when the jaw is closed and the disc fails to maintain its normal reduced relationship to the condyle. The non-reduction disc displacement disorders result in limited range of the motion and the resultant ipsilateral deviation on the opening. So remember these notes that you see here. So what happens is whenever there are different kinds of movements like rotational movements and translation movements, what happens during translation movements, that is the wider movements of the mouth, the condyle and the disc have to move out of the socket, right? So it goes forward and down the articular eminence. And when the mouth opens, mandible moves, rotational movements of the condyles occur within the socket. Here, sometimes, like here, what happens in this is disc displacement. With reduction, you see click sound. And without reduction, you see lock sound. Okay. Here, retrodiscal tissue takes over the place. And then it is highly vascular, so the patient will extremely be in a painful condition and there'll be joint and muscle tenderness, but he or she can exhibit normal interincisal opening, whereas in lock, it's not the case. Systemic arthritis conditions, including rheumatoid arthritis, systemic lupus, and different kinds of diseases, including calcium pyrophosphate dihydrate, pseudo-gout. With these conditions, there are usually other clinical systemic signs and symptoms. So in case of rheumatoid arthritis, lupus, and pseudo-gout, also these TMJ disorders can be seen. Chronic recurrent dislocation. Chronic recurrent dislocation occurs when the mandibular condyle translates anterior to the articular eminence. So let me just go through this. So what happens in recurrent dislocation is when the jaw is really wide, like suppose during cheerleading for a game, what happens is the mandibular condyle translates anterior to the articular eminence. And in that case, what needs to be done is it has to be rotate the jaw down and back to get over the hump of the articular eminence. Just 1 second. Yes. Okay. So in that case, generally it can be, this is a normal procedure performed by the oral surgeon, but if it is chronic, the patients have to be given Botox. Next is ankylosis. Ankylosis can occur intracapsularly or extracapsularly, and it can be fibrous or bony. Bony ankylosis results in limitation of the movement. Trauma is the most common cause of the ankylosis. However, surgery, radiation therapy, and infection can also result in TMJ ankylosis. So surgery, radiation therapy, and infection can also release. So it can be trauma, surgery, radiation, or infection that can lead to ankylosis. And ankylosis is of two types. One is fibrous. Fibrous generally is less painful, but bony is extremely painful. The ankylosis patients presents with severely restricted range of motion that may be accompanied by pain. These patients are often able to demonstrate limited translation on affected site, but nonetheless have severe limitation in interincisal opening. So affected side, in the affected site, they cannot really open their mouth much, but in the unaffected side, there is little bit of movement present. Okay, so here what I'm talking about is, you can see normally this is the articular disc, pink color. This is the condyle. And this is the lateral pterygoid muscle. So when you open the jaw, this articular disc moves, right? See, the movement is downwards. You can see that this also moves along. But sometimes what happens is, this is with reduction, and this is without reduction. So with reduction, what is happening over here is the retrodiscal tissue, is coming in between, and it's extremely painful. Now, and this is without reduction, the locking. So you can hear the click or lock based on the following situations. Now there are different methods. Non-surgical therapy is the first choice. Then if it's not being solved, then there is surgical therapy. Now coming to non-surgical therapy. Non-surgical therapy includes mainly patient education, then physical therapy, then pharmacotherapeutic intervention, and occlusal considerations. Treatment objectives are decreasing pain symptoms and improve function.
Battery 80%.
In cases of, I'm sorry about that. So it's my speaker making some sound. So yeah, so the patient would be first given therapy, then later occlusal considerations. Mainly the main objective is mainly to reduce the pain. In cases of ankylosis and severe symptomatic disease, surgery is preferred. Now, next is counseling. Parafunctional habits can be associated with MPD, and the patient should be counseled concerning any such habits, because those habits also can lead to problems. Like I said, bruxism, and at nighttime having clenching the jaw, and the nail biting, these all can cause it. So the patient should be educated that why he needs to change his habits. Medical therapy. Medications given are non-steroidal anti-inflammatory drugs, NSAIDs, steroids, narcotic and non-narcotic analgesics, antidepressants, and muscle relaxants. Antidepressants are given because the condition is really painful. So that's the reason that these are drugs are being given. The choice of the medication should be based on the diagnosis, etiology of the symptoms, and medical comorbidities associated with individual patient. Now coming to physical therapy. Physical therapy modalities can be very helpful in non-surgical management of the TMJ patient. Now, biofeedback, ultrasound, and transcutaneous electrical nerve stimulation. TENS stands for transcutaneous electrical nerve stimulation. Massage, thermotreatment, exercise, and ionophoresis may be considered modalities. Many of these modalities result in increased circulation to the affected region, facilitating the removal of painful metabolic byproducts and delivering therapeutic medications. It is believed that TENS may override pain input or that it results in the release of endogenous endorphins. So I have written the summary over here. In the physical therapy, biofeedback, ultrasound, and transcutaneous electrical nerve stimulation is done. Massage in the affected area, thermotreatment, exercise, and ionophoresis. TENS, that is transcutaneous electrical nerve stimulation, overrides the pain and results in endorphins release. Occlusion. Splints can be usually classified either as auto repositioning or anterior repositioning. The auto repositioning splint is used for muscle and joint pain when no specific anatomically based pathological entity can be identified. It is used mainly for muscle and joint pain. It works by reducing intra-articular pressure, whereas anterior repositioning protrudes the mandible into forward position. So here only the name suggests, right? Anterior reposition. So you are repositioning it in the anterior way. Protrudes the mandible into the forward position and capturing the normal disc to condyle relationship. So again, occlusal splits are of two types, auto repositioning and anterior repositioning. Auto repositioning is mainly for used for muscle and joint pain. It works by reducing the intra-articular pressure. Anterior repositioning protrudes the mandible into the forward position, capturing normal disc to condyle relationship. So let's see the diagram over here. Here you can see how the use of the splint in the diagram is affecting the TMJ. Okay. So now just a quick review. Non-surgical is mainly the goal is to reduce the pain. So first physical therapy is done, and then counseling is done, and then the medication is given. Counseling to change the habits like nail biting, bruxism is given to the patient, and based on the patient history, the drugs are given. Physical therapy, biofeedback, ultrasounds, and transcutaneous electrical nerve stimulation is done. Massage, thermotreatment, exercise, ionophoresis is done. Mainly TENS overrides pains, results in endorphins release. Occlusal splints are of two types, auto repositioning and anterior repositioning. Auto repositioning, mainly the occlusal splint works by reducing intra-auricular pressure, whereas anterior repositioning captures the normal disc to condyle relationships. Here, it protrudes the mandible into forward position. Now, quick recap about the myofascial pain disorder. We learned this is the main common cause of masticatory pain. It can, let me use a different color. Okay, so the main part about this is it's common. And then the pain is seen near the ear, and it's diffuse pain related to, involves the muscles of mastication, can be related to the habits like clenching, nail biting, and bruxism. Patients who have nocturnal bruxism will experience symptoms in the morning. Disc displacement disorders, it's of two types. One is with reduction, without reduction. With reduction, you see click sound. Without reduction, you see the lock. Here in the diagram, you can see with reduction. So what happens is normally the articular eminence is present in between, right? But in cases when the mouth is wide open, what happens is sometimes the retrodiscal tissue comes in the place of the articular eminence, and it's extremely painful condition. Okay, and without TMJ, without reduction is lock. Here the condyle is stuck, resulting in the limited range of motion and ipsilateral deviation to the opening. If one side is affected, mandible is deviated to the locked side. So here mandible is deviated to the lock side. Now ankylosis can be intracapsularly or extracapsularly, and it can be fibrous or bony. Fibrous is less painful, bony is more painful. It can be due to trauma, surgery, radiation, or infection. Recurrent dislocation, like in shearing, when the jaw is open way too wide, this can happen. And normally, just the jaw needs to be rotated and so that it gets over the hump of the articular eminence. But in chronic case, Botox injections are given. Now, this is the pseudodisc adaptation. Pseudodisc adaptation is when the disc becomes anteriorly displaced, the retrodiscal tissue undergoes fibrous adaptation, producing a functional interpositional disc. Like I told you, the retrodiscal tissue takes over, and then it will form a pseudodisc adaptation. Okay. Now, we studied about occlusal splints. Occlusal splints are of two types, auto-repositioning, anterior repositioning. And next, arthrosentences. Arthrosentences can be shown or to be of benefit in patients with internal derangement. 1 or 2 needles is placed into the superior joint space. So in the superior joint space, needles are placed. A few millimeters of saline or lactated ringers are injected. Some surgeons advocate a lavage at this time as well. It is hypothesized that the efficacy of the modality is based on the distension of the joint capsule, release of adhesins, and the potential for removal of chemical mediators associated with the joint pathology. So here 1 or 2 needles are inserted and the saline is injected and it relieves the pain. Now coming to the surgical treatments. Okay, just give me 1 second. Okay, so surgical treatments of the temporomandibular joint are arthrosentences, arthroscopy, disc repositioning, disc repair or removal, condylotomy, and total joint replacement. It depends on the condition, patient to patient. Okay, arthroscopy involves the placement of 2 cannulas to allow access for intracapsular instrumentation of superior joint space. Disc manipulation, disc release, posterior band cautery, and disc repositioning and stabilization techniques have all been described. This appears to be effective modality in a select group of surgical patients and offers a potentially less morbid access to the joint. Okay, arthroscopy is nothing but here you can see it is 2 cannulas to allow the access for the intracapsular instrumentation of superior joint space. This is good enough for the both to remember. So, arthroscopy. Arthrosentences is you inject, here we have studied about it, you inject 1 or 2 needles and it's placed into the superior joint space with the saline. So 2 needles with saline in the superior joint space. All right. Now, coming to disc repositioning surgery, open arthroplasty is used in patients with painful, persistent clicking, popping, and closed lock. Disc reposition. So you're repositioning the disc. The disc is mobilized and a posterior wedge may be removed with suturing, used to reposition the disc into more anatomically desirable position. Generally, good results are seen initially, but 10% to 15% of the patients report with no benefit or worsening symptoms post-op. So what happens is you're repositioning it. The disc is mobilized and a posterior wedge is removed and then operated for more anatomically desired position, but there is no guarantee that the patient would feel better. Disc repair or removal. So when the disc is entirely damaged, then it would have to be removed. There is a wide variation in the reported results, with this procedure ranging from excellent resolution to severe degeneration, and it's associated with pain and dysfunction. When the disc is removed, recommendations for the replacement have been made. Some prosthetic materials have been proven to be problematic, so there is tendency to favor the autogenous material. Mainly it is from the temporalis muscle or the fat and auricular cartilage. So here we read about arthrocentesis, that is, 2 needles are injected with saline in the superior joint space. Arthroscopy, where intracapsular instrumentation is done into the superior joint space. Disc repositioning surgery or open arthroplasty, where disc is first mobilized and then changed into the anatomically desired position. Disc repair or removal, it is mainly done when it is entirely damaged, but prosthetic replacement have not given good results. So the autogenous materials are preferred from temporalis muscle, fascia, and fat. Now coming to condylotomy. Condylotomy is accomplished by performing an intraoral vertical ramus osteotomy. So here you can see intraoral. So intraoral vertical ramus osteotomy. This theoretically, so condylotomy is removing a part of condyle. This theoretically allows the soft tissues to passively reposition the condyle and disc into more functionally neutral position. This has been described the treatment for internal derangement with or without reduction, DJD, and chronic dislocation. Total joint replacement is indicated only when it is severe, as in case of rheumatoid arthritis, ankylosis, neoplasia, and post-traumatic destruction. Costochondral bone graft reconstruction is the most common autogenous material used. However, this does not address the fossa pathology, which may be significant and must be addressed in pathological joints associated with the use of prosthetic materials. So total prosthetic joint reconstruction usually involves both a prosthetic condyle and a fossa. Results with this technique have been variable and may deflect the complexity and diversities of the case studied. So this is normal TMJ, where you can see the disc, and this is lateral pterygoid muscle. Dislocated disc, you can see that it is dislocated over here, and arthritis painful condition over here. So surgical treatments is arthrocentesis, arthroscopy, disc repositioning surgery, disc removal, and condylotomy, where intraoral vertical ramus osteotomy is performed, and total joint replacement, but it is only indicated in very, very severe conditions because there are not much positive results because it involves prosthetic condyle and fossa replacement. So that's all for now. In the next class, we'll be studying about biopsies.